All right, everyone, let's go ahead. Welcome. I'm Jill Escher. I'm your host today for the fourth in our spring webinar series. We're very happy today to be presenting Amy Lutz. We did change the title of this this webinar because I noticed that we had erred in our original title, but the title is Treating Dangerous Behaviors in the Developmentally Disabled. I believe Trudy will not be joining us today. Amy, are you there?
I'm there, Jill.
Okay, so I'm in California and Amy's in Pennsylvania, but through the magic of technology, we are together today. Just so you know, our spring webinar series has archived the first 3 webinars. You can see them here, the Job Club, Guy Stuff, and Autism in the Criminal Justice System. They were all fantastic. And after the webinar today, you can see that we have 3 others coming up in the spring series. April 27th, we're going to be speaking with several researchers from UCSF about their amazing programs and some of their research opportunities that people might want to participate in. On May 25th, we have a packed panel. We're talking like 7 or 8 people on this panel talking about social opportunities for adults on the spectrum in the Bay Area. And May 31st, Dr. David Amaral from the Mind Institute will be giving us an inside look at what's happening in research there. And then probably most pertinent to the audience today, in the fall, we will be presenting an online symposium on severe behaviors, and maybe we'll have Amy back for that as well. And we'll be talking about a lot of different aspects relating to severe behaviors, and that includes treatments, includes housing, day programs, employment, legal issues, sexuality issues, criminal justice issues, a bunch of stuff. So look for an announcement about that either on Facebook or sign up for our newsletter at sfautismsociety.org. And you can sign up for the webinars here at this URL. And, oops. Please note, if you have a question, please type it into the question box and the control panel, and at the end of Amy's presentation I will field those questions and pitch them to her. If you're calling in or for some reason you can't use the question bar, you can just email me directly at jill.escher@gmail.com. That's Escher, E-S-C-H-E-R. If you can't see the presentation screen right now, please look under your browser. Sometimes it's hiding there. Please know that all attendees are on mute. Amy and I have our mics live, and that's about it. And the webinar is being recorded and will run for about an hour. If we go over, it's totally fine. We're not too persnickety there. So introducing Amy. Amy is the author of a book that she will be talking about today called Each Day I Like It Better. And Amy, I have to ask, is that from the Sesame Street song about the letter D?
That is from the Sesame Street song about the
letter D. You know that I'm an autism parent because I knew that line because I've heard that song so much. Each day I like it better. Okay, anyway, I had to ask that. And she is a writer at Psychology Today. She writes a wonderful column called In Spectrum, which you should check out. And I know Amy because she was our keynote speaker at our conference 2 years ago, speaking about housing options for adults with autism. In a wonderful presentation. That's archived online in our files for our 2015 conference, linked from our homepage. And recently, I think there's another video that's coming out of Amy presenting on housing at Autism Science Foundation's Day of Learning recently. So you might look out for that one. I think we'll post that link on our webinar website when I get it. Okay? And with that, I am going to, hold on, turn it over to Amy.
Thanks, Jill. Thank you so much, and thank the Autism Society of the San Francisco Bay Area for inviting me to speak on this topic, which I think is so critical. Let's get started. Can you see
your screen yet? Did you accept?
Okay, here we go.
There you go. Perfect.
All right. Okay. So 2 warnings before I dive into this. Some of the pictures in this presentation are disturbing, although I found that parents and caregivers who love and work with violent autistic children and adults have a very high tolerance because they've seen all of this before. Secondly, and very importantly, I am not a doctor, so please consult with one before pursuing any of the treatment options we'll be discussing. And I should add a third, which is this is my first webinar, so I apologize in advance for any technical glitches we may encounter. An estimated 700,000 kids in America are living with autism. Based on the current prevalence rate, which is 1 out of 66, the population will increase by 60,000 each and every year. The question is, how big a problem is aggression and self-injury in the autistic population? According to the CDC, 40% of the autistic population also suffers from intellectual disability, 20 to 30% is nonverbal, and a 2013 study found that more than half of autistic children exhibit aggressive behaviors. And what makes all of this even worse is that these conditions often co-occur, resulting in a significant population of individuals who are nonverbal or minimally verbal, significantly intellectually disabled, and aggressive. So violent behaviors are very common in the autistic population. These boys in the picture are primarily self-injurious. You can see protective equipment like helmets, arm stays, and bandages. The boy on the bottom left is in a medically induced coma following eye surgery to repair the detached retinas he incurred from punching himself in the face more than 200 times an hour. So yes, it is a big problem, but because the media tends to focus on happy stories like autistic kids who sing with Katy Perry or kick field goals or are gifted painters, we don't tend to hear about aggressive kids until tragedy strikes. The top picture is of Kent State professor Trudy and I'm not sure I'm pronouncing that right, I apologize if I'm not, and her son Skywalker, who beat her to death when he was 18. The bottom picture is autism advocate and blogger Kelly Stapleton and her autistic daughter Izzy. Last year, Kelly Stapleton tried to kill herself and Izzy because she no longer could deal with Izzy's violent behaviors. Both of them survived. If you take away one thing from this presentation, I hope it's that these violent behaviors are often treatable. And it's a message that really needs to be spread because I honestly believe there's nothing more terrifying and isolating and heartbreaking for a family than caring for a child who is a constant threat to hurt himself or herself or others. This is my family. It's an older picture, a couple years old at our shore house in Atlantic City, New Jersey, but I'm sure anyone, a family, including an autistic child, knows it's really hard to get a picture where everybody's looking at the camera and smiling, so I'm still using this one. Right in the middle is my son Jonah on the adapted bike with his dad, and now Jonah is 18. And boy, we look really happy in this picture. But life wasn't always so happy. Jonah is autistic and suffered from aggressive and self-injurious behaviors for most of his life. These rages were frequent, intense, and unpredictable, occurring even during his most preferred activities. These photos were taken during a self-injurious episode, but Jonah's aggressive outbursts were even more dangerous. In kindergarten, he broke a teacher's nose, and he often left us, his teachers, and his aides bruised, bitten, and scratched. We lived in constant fear he would attack one of his siblings, but thankfully he never did. These are some of the strategies we tried to deal with Jonah's aggressive behaviors. Some of them, I'm sure many of them, may look familiar to you. We tried alternative therapies like diet, vitamins, auditory integration training, hyperbaric oxygen treatments. We also did brushing, virtually everything we could think of to try. We had, of course, very involved behavior plans involving aversives, extinction, using verbal behavior, ABA. We were trained in restraint, and we had token economies. And medications. I'm not even going to try to pronounce these medications, but as you can see, we tried all the antipsychotics, we tried antidepressants, we tried all kinds of things, stimulants, to try to control these violent behaviors, and nothing worked for very long. In fact, Jonah's behavior was so dangerous to himself and other people that he ended up spending almost a year inpatient on the neurobehavioral unit at the Kennedy Krieger Institute in Baltimore. While he was there, he received a secondary diagnosis of bipolar disorder with catatonic features. Kennedy Krieger is the most well-known and well-respected of the 9 inpatient units in this country that treat solely kids with developmental disability and dangerous behaviors. The waiting list at Kennedy Krieger can be several months to a year or more because they only have 16 beds. We waited 4 months during which Jonah was homeschooled because he had been expelled from his specialized school for autistic children because even they couldn't manage his behavior there. Jonah's secondary diagnosis of bipolar disorder turned out to be very useful and informative, and it's important to look for these secondary conditions. 70% of autistics suffer from at least one comorbid psychiatric disorder, such as anxiety, mood disorders, or catatonia, and almost half meet the diagnostic criteria for 2 or more disorders. Jonah's doctors believed his rages were driven by his bipolar disorder, not his autism, and they treated him with the medications typically prescribed for bipolar patients, lithium and the antipsychotic Abilify. So when he was discharged in November 2008, Jonah's mood was stable and his aggressive and self-injurious behaviors were greatly diminished. So he did very well at Kennedy Krieger, and I just want to emphasize this point on the screen, which is that often the symptoms, these aggressive symptoms, although many doctors, many pediatricians, or even child psychiatrists may dismiss aggressive and self-injurious symptoms as part of the autism, these symptoms can have a separate etiology and can be treated with the same interventions prescribed for neurotypical individuals with the same disorders. So it's very important to separate out what's part of the autism and what might be driven by a comorbid psychiatric condition. So here's the million-dollar question, which is how can you tell whether the dangerous behaviors of an autistic child are due to a comorbid psychiatric illness or not? Well, you do a functional behavior assessment and try to assess whether the behaviors are operant, that is triggered by the environment, or intrinsic or automatic, which means they are caused by a neuropsychiatric impairment. So if your child rages because he wants a cookie, or he's learned that he doesn't have to do his schoolwork, or that his mom comes running whenever he engages in aggressive behavior, none of that is going to be helped by changing his medication or starting ECT or any other medical intervention. Those kind of cases demand a very sophisticated and informed behavioral intervention. However, if your child rages across all environments unpredictably, then it's very likely that his behaviors are caused by a neuropsychiatric impairment. Often, the most severe aggressive and self-injurious behavior has both operant and intrinsic functions. So, for example, a child might have an intrinsic aggressive behavior, but then that behavior might be reinforced because his mom comes running every time he attacks his aide or his sister, for example. Autistic kids often don't respond to meds or have bizarre side effects. So less than a year after discharge, Jonah's behaviors were worse than ever. The most common form of medical management is prescription medication, which I'm sure everyone on this call is familiar with. One 2013 study found that nearly 2/3 of autistic kids had taken psychoactive medications, and 1 in 7 kids had been prescribed 3 or more drugs at the same time. But only 2 medications, risperidone and aripiprazole, which is Abilify, have been shown to reduce aggression and irritability in multiple large controlled studies. And I took this information from the American Academy of Child and Adolescent Psychiatry's Parent Medication Guide, Autism Spectrum Disorder, which is now available free for download on the ACAP website, which is www.acap.org. So I encourage everybody to pick up that new and free and very helpful resource. But of course, just because only 2 medications have been shown to reduce aggression and irritability doesn't mean that many other drugs aren't prescribed off-label. Medical marijuana is something I'm very interested in as far as its usefulness treating these types of behaviors, because of all the interventions that are used, it's probably the safest and has the fewest side effects. I will say there is no clinical evidence to support the use of marijuana in autism, and researchers are concerned about possible risk factors such as the development of psychotic disorders and cognitive impairment, although the evidence for that is questionable. It is very difficult to dose consistently. That is a clear problem with this therapy. I do know several families personally who saw some benefit from medical marijuana, but then they were unable to maintain those gains. But that said, there are too many anecdotal reports of kids really responding well to medical marijuana for me not to think that it has a lot of potential to treat aggression and self-injury in our kids. So I'm hopeful that more research may be done on this indication. For us, for my family, medications ultimately failed, as I mentioned, and marijuana isn't legally available in our state of Pennsylvania. So what worked for us? This is a very famous scene from One Flew Over the Cuckoo's Nest of Jack Nicholson receiving electroconvulsive therapy, or ECT as it's known for short. Probably nothing has done more to stigmatize ECT and misinform the public than this particular movie. It came out over 40 years ago, and still many people with no direct experience with ECT consider it a punishment, a form of torture. We knew it had been successfully used at Kennedy Krieger, so we weren't scared about using it. But you should know that ECT does not look like this, and in fact, it didn't look like this in 1962 when Ken Kesey wrote the book the movie was based on. This is a picture of a person actually receiving ECT. It's done under general anesthesia with muscle relaxants, so there's no thrashing. And an estimated 100,000 Americans get ECT every year. So, as I mentioned, ECT has been done this way under general anesthesia with muscle relaxants since the 1950s, and it is not aversive. There's no pain. One British study found that half of ECT patients found going to the dentist was worse than getting ECT. And I also want to point out here, as a point of clarification, that ECT is not the same as the contingent electric shock administered at the Judge Rotenberg Center in Massachusetts, which uses shock on conscious children to stop certain behaviors, sort of like the way dogs are trained to avoid an electric fence with shock collars. So there's been a lot of confusion recently that ECT, and when it's known or referenced by its older name, which is shock treatment, is the same thing as what's going on at the JRC. So, as I mentioned, this is a common, or relatively common, treatment in the psychiatric world. The most common indications are affective disorders, acute psychosis, catatonia, and Parkinson's disease. And that's what ECT does for Jonah. It controls his bipolar disorder. So why did we try ECT? Well, there were a few reasons. First, there's a precedent. At Kennedy Krieger, 11 treatment refractory patients all experienced significant improvement with ECT. So these are patients, who are at Kennedy Krieger, which sees the very worst cases of kids who have detached their own retinas, who have concussed and severely injured other people, including their parents, and they didn't respond to the brilliant minds at Kennedy Krieger that include the best child psychiatrists, the best behavior therapists, working together to try to stop these behaviors. And of the of the kids who didn't respond, they all 100% experienced a significant improvement with ECT, which we found very hopeful. Since then, other respected hospitals have reported similar findings. Mount Sinai in New York, a hospital at the University of Michigan, the University of Mississippi, and the Salpêtrière in Paris, just to name a few. If you're interested in seeing more of the studies that support the use of ECT in the pediatric population in general and in the developmentally disabled pediatric population in particular, I compiled the bibliography of over 80 studies and reviews, and it's on my author website, which is www.amysflutz.com, and there's a slide at the end of my presentation with all my contact info, including this website, so you don't have to write it down right now, but if you're concerned about whether or not this is a kind of crackpot fringe treatment or whether or not this is a well-established and supported medical procedure, I strongly encourage you to check out the bibliography and just look up the sources. There's, those 80 studies, it's only a fraction of the 10,000 citations on PubMed about ECT in general, the safety and efficacy of ECT in general. The reason why there are so many more for the adult population is because it's not used that often in the pediatric population. Many of the psychiatric disorders for which ECT is indicated don't hit people until they're in their 20s. So it's well researched in the adult population, and there are increasingly more studies of supporting its use in the pediatric population. Another reason, ECT has a more benign side effect profile than psychotropics. Antipsychotics, the most common medication prescribed to treat aggression and self-injury, can sometimes cause permanent and occasionally fatal side effects, including akathisia, tardive dyskinesia, glaucoma, and neuroleptic malignant syndrome, which, by the way, ECT is very effective in treating neuroleptic malignant syndrome. Over 200 children died in the U.S. between 2000 and 2006 due to complications from antipsychotics. But since it was first used on kids in the 1940s, no child has ever died from ECT. The most common side effects from ECT are headache and nausea, although short-term memory loss is not uncommon during the acute course of treatment. And final reason, which I think a lot of parents who are with me right now can relate to, is that we really wanted to try something new. After trying almost 20 different medications, none of which stabilized Jonah over the long term, it seemed unlikely that slightly different formulations would help. And honestly, I dreaded the thought of going through what you have to go through when you make a big medication adjustment, which is very slowly, weaning Jonah off of his medications and then starting to build up more medications very slowly. And it just seems like a shot in the dark sometimes to find the right combination of the right medications at the right dosages, and in the meantime, I'd have to worry about protecting him, protecting my other children from him, and protecting myself from him, and protecting himself from him, making sure he didn't engage in any really self-injurious behaviors. Didn't seem like something we could manage safely in our home. In March 2010, we started ECT. Aggression dropped by over 90% during the acute course of treatment. The acute course, everyone who gets ECT, whether they're neurotypical or autistic, goes through an acute course, which is when you get multiple treatments, usually about 3 treatments a week, until the symptoms are ameliorated, and then you can kind of taper down to a maintenance course. For Jonah, those treatment intervals were increased to his current schedule, which is 1 treatment every 9 or 10 days. I know some families manage to stretch it out to once every 2 weeks, but I don't know any families whose autistic kids get ECT for this indication who can go much longer than that. ECT is like dialysis. It causes changes in the brain that are transient. So if you go too long, the hormones and the neurotransmitters that are released during the seizure that's generated during ECT those are reabsorbed by the brain, and they're no longer therapeutic. 7 years later, now Jonah's rages are still gone. He lives at home. As I think I mentioned, he's 18 years old, and he enjoys all his favorite activities like swimming, boating, and hiking. 4 years ago, Jonah switched schools, moving for the first time from a more restrictive to a less restrictive environment. And now he's out in a community-based school, spending all day going from, he goes to the gym and runs on a treadmill, and then he goes to the supermarket and picks out some food. He goes, prepares it. He goes to different work sites and recreational facilities. So, and all of that is made possible by ECT. Before that, the only person who can manage him out in the community was my husband, and that was when he was 10 years old. These pictures are from a cruise we took in 2014, which is something we never would have tried to do before ECT. We've seen no obvious side effects from Jonah's 250 ECT treatments. We've seen no evidence of memory loss, although in this population it's hard to assess, of course, because of his limited verbal skills. But his teachers have not noticed any impairment or any difficulty with previously acquired material. His academic performance dramatically improved after ECT once his mood stabilized and he was able to focus on his schoolwork. So before ECT, Jonah learned an average of 7 new skills per month. In December 2010, he mastered 52 new skills. And I don't have any more recent data than that because shortly after that was when he switched schools to the community-based school where they don't keep data about those very precise ABA-type skills that his old school used to track. And I can assure you that ECT is not aversive to Jonah. He never complains about going, and he fully cooperates with the IV placement. He just climbs on the gurney, and he likes to talk with the anesthesiologist about the treat he's going to get afterwards, because you have to do it on an empty stomach. So he always wants a black and white cookie afterwards. And he recovers so quickly from the seizure and the general anesthesia that he's able to go to school immediately afterward. Although I will say that not all the kids that I know who get ECT kind of bounce back so quickly. Sometimes they go home and have a nap in the afternoon because the seizure is fatiguing, but so is the general anesthesia. A lot of it depends on how well they're able to recover from the anesthesia. The fact is, most treatments for severe illness have risks and benefits that need to be considered and weighed. Chemotherapy and heart surgery have potential cognitive side effects that are worse than ECT. These young men are now living at home with their families, attending school, and enjoying all their favorite activities. Without ECT, they would all be in restrictive residential placements, as would Jonah, or worse. The boy on the right is the one who was in the medically induced coma for detaching his retinas. This is an old picture, a few years old now, but I can tell you he is still doing well and living at home. Before ECT, he had spent more time in hospitals than at home over the course of his life because of his self-injurious behaviors. So a question I often get asked is, why isn't ECT used more frequently in this patient population if it's so transformative? Well, there are a few reasons. First of all, there are legal restrictions in some states, just a few. 5 states, including California, Texas, and Colorado, prohibit the administration of ECT to minors altogether. Other states have onerous regulations for incapacitated patients, such as Connecticut, where ECT can only be done with a court order that lasts no longer than 45 days. And these types of regulations are always old and reflect misinformation about ECT. Sometimes this therapy is not accessible to families. Most ECT providers are geriatric psychiatrists, and autistic adolescents can be extraordinarily difficult patients at the beginning. So ECT providers may not be willing to, they may not be willing to treat autistic kids, or the family may find that it's not an ECT provider convenient to their home. the first time we brought Jonah for ECT, I think there were about 6 people holding him until he was sedated, just because it was someplace new. He couldn't really understand what was happening. You know, it didn't reflect philosophical opposition to ECT in particular, just kind of a panic. And now, as I mentioned, I mean, it took maybe 1 or 2 sessions before he knew the routine and he was fine. But ECT providers, you know, are definitely not used to that type of behavior and may not be willing to accommodate it. What I explain to ECT providers is that although it can be difficult to see someone agitating and protesting, this is common behavior for our kids and doesn't have anything to do with ECT in particular. For example, the hardest thing we ever had to do with Jonah, the thing that required the tightest and most prolonged brute restraint, was taking him for haircuts when he was younger. The fact that these kids have challenging behaviors is the reason why they need ECT. It shouldn't be the obstacle that keeps them from getting it. On the flip side, the child psychiatrists who do treat autistic kids often aren't aware that ECT can help with aggression and self-injury. They might fail to recognize comorbid disorders like catatonia or bipolar disorder, and as we discussed earlier, tell parents that aggression and self-injury are just part of the autism. Or even if they recognize these coexisting conditions and the medical management they require, they just may not know that ECT can be so helpful in this population. But I'm hopeful that will change with some recent and upcoming exposure. ECT was included in the Autism Spectrum Disorder Parents Medication Guide as a therapy that is useful when medications fail. And again, you can get that off the ACAP website. There was a recent article by Apoorva Mandavili in the online magazine Spectrum that was reposted by The Atlantic, called How Shock Therapy is Saving Some Children with Autism. And forthcoming next month is a documentary made by the BBC called Our World, My Child, ECT, and Me, and it features our family and another family who had recently started getting ECT for their autistic daughter, and that's going to be available, you know, as of next month. It's really important, though, to note that ECT is not a cure for autism. ECT is very effective treating the aggressive and self-injurious behaviors caused by comorbid psychiatric disorders in autistic kids, but it does not address the core symptoms of autism, including deficits in language and socialization. So we still struggle with common autistic behaviors like elopement, food stealing, and if you haven't figured out what this picture is of, I can tell you that Jonah has a bizarre and expensive compulsion to throw electronic devices out the windows of moving cars. And if you've ever wondered what an iPad looks like after it's been run over, that's what it looks like. ECT, unfortunately, does not address any of those behaviors. But by stabilizing Jonah's mood, it has allowed us to proceed with behavioral plans for all of these things. And I will say that he hasn't thrown an iPad out the window for a couple of years. We've worked really hard on that, and I think we've made a lot of progress.
Amy, we have a lot of thrown iPads in our house. I have a box of iPads that look just like that. And the iPad repair technician is our best friend. So.
I agree. You know, every time I go to the Apple store and get, you know, my replacement iPad for $50, my husband will always ask me, when are they going to cut you off over there? And you know, that's why Apple is my favorite company.
Yay.
This is my book about our experience with ECT. It also includes chapters on 6 other families who used ECT, including one family whose son did not respond to ECT. It was the only family I met in the years since Jonah we've even thought about ECT where the child did not respond. And I will say that the family was not sorry that they tried therapy and it was not aversive and there were no negative side effects, but it just wasn't helpful. He had a very complicated case. And just in regards to what Jill asked about the title, that's Jonah's handwriting at the top, and he wrote "Each day I like it better" when he was younger, and I didn't recognize it as a line from a Sesame Street song at the time, but figured it out later. I thought he was making some kind of grand metaphysical statement about his life, which was so inspiring to me. And I still wonder what he meant by that, because he could have just written another line from the song about the letter D, but that's the line he chose.
I'm sorry, did he write that after he had started his treatments?
No, this was when he was a small boy, like 7.
Oh, okay.
This is the EASY Foundation. It stands for Ending Aggression and Self-Injury in the Developmentally Disabled. We started it with 2 other families in 2012. It's a foundation that supports autistic individuals with dangerous behaviors and their families. It's not just a pro-ECT foundation, but we do maintain a resource guide of schools, child psychiatrists, and other providers experienced treating this population, including we do have an ECT provider guide, because we really believe that positive outcomes depend so greatly on connecting families with the right services. So we've held symposiums on treating dangerous behaviors in this population. We also did hold a housing symposium, and we really just exist to be a resource to the families whose children exhibit the most challenging behaviors. I have my contact information here. There's my author website, which has links to my article on ECT for Slate, which you can just access for free. It has my email if you want to email me specific questions at some later date. And you can friend me on Facebook. I've just recently added that contact information because I do share a lot of information about issues pertaining to those on the more severe end of the spectrum, and I think it's really important that those of us who are fighting for care for our severely autistic loved ones are connected. I think I've seen in the last couple of years how important it is and how much I've learned from other people in my network, so feel free to friend me on Facebook. I accept all requests. And now I'm ready to take some questions if there are any, Jill.
Thank you, Amy. That was wonderfully informative. And yes, we have a number of questions that have come in. Some are a little bit off topic, but let's go. There's so many, I'm just going to plow forward. Okay. This is fascinating. What do researchers attribute to its effectiveness, i.e. what causes this to work in reducing or eliminating SIBs?
Okay, well, the mechanism by which ECT works in anybody, autistic or not, is not 100% understood. There are different theories as to why the seizure in the brain is therapeutic. So that is the therapeutic element, is the seizure in the brain, which is why other types of neural stimulation like TMS, which is getting a lot of attention recently, they're not equivalent because they don't cause a seizure in the brain. And that seizure has documented effects, such as an increase in certain neurotransmitters and hormones that are therapeutic to those with certain conditions. It also causes neurogenesis, the growth of new neurons in the brain, which is also how antidepressants are believed to work. But I can't tell you more specifically. It's not very well understood, but I will say that ECT, like I mentioned, is used to treat these psychiatric disorders like catatonia and bipolar disorder in the neurotypical population.
Got it. Is there data specifically about adults, or at least those post-puberty, and if maybe their needs for ECT become reduced over time?
That's a great question, and we don't really know the answer to that. I will say that I think the first autistic kids who started receiving ECT for aggression or self-injury are probably now in their mid-20s. Now, none of those kids have been able to stop getting ECT, because as I mentioned, the changes to the brain are transient, and their comorbid psychiatric conditions are chronic, so they just keep coming back. Even in the neurotypical world, some people need maintenance ECT for life to keep their acute depression from coming back. Kitty Dukakis is a famous example of someone who gets ECT once every 4 to 6 weeks to keep her depression from coming back. And there are others who can go years, but that's a little different because depression is an episodic illness. So once the episode has resolved, it may be years before it comes back, whereas usually the conditions that these autistic kids are diagnosed with, and the most common, are bipolar and catatonia, an agitated form of catatonia that results in, especially in repetitive self-injury. Those are chronic conditions. So until they find a way to, more permanently address those issues, I think that Jonah could be getting ECT, for the rest of his life.
Yeah, we had a number of questions actually related to this, idea of intermittent behaviors, right? Intermittent explosions, intermittent aggression, right? If they're not consistent, could ECT still be of use in those patients?
Well, I think the best indicator that I found, or the most common denominator in the children and young adults who get ECT for their explosive behavior, is the fact that it's not predictable and it occurs across all environments. That is, there's no environmental trigger, because that does suggest some kind of internal etiology, and that's when you look at medical causes. But it's really important to do that very deep functional behavior assessment and make sure that there aren't operant triggers or environmental triggers that are causing the behaviors, because no medical treatment, ECT or medication or marijuana, is going to address behaviors that are the result of environmental triggers.
Got it. Is ECT used as a treatment for PTSD in people with autism?
I've never heard of ECT being used to treat PTSD in people with autism or people without it. So it's not an indication as far as I know.
Okay. We have many more questions, so I'm just going to keep lobbing them, okay?
Okay, go.
Is there concern about repeated general anesthesia? Is ECT safe for an individual with a known seizure disorder?
Well, ECT does raise the seizure threshold, so it's one treatment that actually scientists are looking at to treat status epilepticus, the kind of repeated seizures. So it is safe for people with seizures. The repeated general anesthesia. Yeah. Well, as I said, kind of Jonah's part of an experimental generation. We can't look at autistic adults who are 60 and have gotten 1,500 ECT treatments over the course of their lives to see if we can notice any permanent side effects. But I will say there are a couple of autopsy studies in the literature that looked at people who died, neurotypical people who died of an old age after hundreds or even over 1,000 ECT for depression, typically, and they have found no structural brain damage or any indication that the ECT or the general anesthesia was harmful. But again, of course, we could definitely use some more research on this. It's such a small group, though. I don't know that we'll ever have the research to 100% answer that question.
Right. Okay. Here's one that I believe you already answered. Can individuals with epilepsy safely have ECT? And your answer was yes.
Yes.
Does insurance typically cover ECT?
Yes, it does, and it almost always has in the past. ECT is expensive. I think looking at the statements we get from our insurance company, the hospital charges about $1,200 every time. But because it's so effective in managing certain psychiatric disorders, these insurance companies routinely cover ECT. And I did just hear recently of one family having trouble with their insurance company, though, so it's absolutely worth a phone call to investigate.
Okay. Let's see. I don't really understand all this, but our psychiatrist required an Ativan challenge prior to considering ECT. Is this typical? And I don't know what she means by an Ativan challenge.
I do. So I'm guessing her child has been diagnosed with catatonia. And so catatonia has two phases. There's the retarded type of catatonia that people are mostly familiar with, where there's freezing and posturing, basically slowing down, prompt dependence. And then there's the agitated form of catatonia, where there's kind of purposeless movement that could also result in, that could also look like pounding yourself in the face, hundreds of times an hour, or just raging over nothing. And catatonia has two treatments. The first is benzodiazepines like Ativan. So they'll always try Ativan first to see if it's useful to break the catatonia. And then ECT is almost always the second line treatment of catatonia. So yes, I think that's very common. But what I found is that, well, at least with the families I've come to talk to, is that benzos may work at the beginning, but then the kids almost always develop a tolerance for them, and the doses have to keep going up until they go to like truly dangerous levels, and that's usually when ECT is considered. But if our child can get benefit from Ativan, then that's great.
Got it. We have many more questions, but I'm going to sneak in a few.
Okay.
Just logistically, I'm curious, from the time you arrive at the hospital to the time you leave, how long does the treatment take, and how long is actually spent actually getting the ECT within that period?
Okay, well, the seizure lasts about 2 minutes, maybe a little less, and so it takes a couple of minutes for them to insert the IV and administer the general anesthetic, and then it takes about 15-20 minutes for Jonah to wake up after. We have to be at the hospital about 7 o'clock in the morning, and our hospital, which is the Belmont Hospital in Philadelphia, they've been really great about treating kids like Jonah and who might have trouble waiting, so they always treat Jonah and the other autistic kids who are going first. And then I'd say we're out by about 8:30.
Okay, so about an hour and a half.
And a lot of that is, sometimes we don't, because the doctor doesn't often show up at 7, so we have to wait for the doctor to get there. The whole thing is pretty fast. I would say from when they start the procedure to when we're out of there, it might be 40 minutes.
Okay, and you said, I'm sorry, you go about every 10 days now?
Yeah, every 9 or 10 days. Kind of depends how the weekend falls.
Okay, and also we were talking before we went live about sleep, and if there are kind of side benefits to sleep. Sleep is a huge issue for a lot of these kids, and if you can talk about your experience and maybe what you've seen in the literature.
Right. So Jonah, when before the Kennedy Krieger days, I'll say, before he was appropriately diagnosed with bipolar disorder, he had really disrupted sleep. There were plenty of nights. I know maybe everyone on this call can relate to being up all night with your child or being woken up at 2 in the morning and desperately trying to coax them back to sleep. But now Jonah sleeps through the night every night, and it's because the bipolar disorder, the affective disorder, drives a lot of sleep disruption. So now that the affective disorder is under control, his sleep has completely normalized, and he sleeps well. He's usually asleep by 9:30 or 10 at night and sleeps until 6:30 or 7 in the morning every night. So I think it's really important, even if you don't end up going down the ECT road, is that you consider the sleep disruption something that can be separately treated, and it might be a result of an unstable mood, and look into that as a route to treat it.
I'm curious, are you using any medications for Jonah now?
Yeah, he's still on lithium and Abilify, and I would love to get him off the Abilify, but it's all these things together that keep him really stable.
All right.
So let me add, Jill, there is something I do want to add, which is if you're considering getting ECT, it's really important to have a child psychiatrist also to work to kind of make a treatment team, because most ECT providers are geriatric psychiatrists, because that's the population most likely to receive ECT is the elderly with depression that has to be resolved quickly. So these geriatric psychiatrists, they don't know anything about autistic kids or the medications required to maintain these gains that they get from ECT. So we still see Jonah's psychiatrist from Kennedy Krieger, and often it's this inability to put a team together that is a real obstacle to getting ECT. So just because you get ECT doesn't mean you don't need a great child psychiatrist to be on board also. You need both of those things.
Okay, good. Okay, a few other questions. Some are a little bit off topic. But I know you addressed medical cannabis to address some of the symptoms of autism, including aggression and anxiety. Um, if it were legal in your state, would you be trying that as well? Is that the only barrier? I mean, you seem to think that there was enough anecdotal evidence to suggest efficacy, at least in a subset of people.
Oh, I would definitely try it. I would try it in conjunction with everything else that we're already trying. I might try it on days, Jonah's mood still can be variable. I mean, he doesn't rage and he doesn't attack us anymore, but he does engage in some mild SIB, like biting his hand when things aren't going his way, or sometimes it's not exactly clear why, so it just might be a little breakthrough of the manic symptoms. And those are times when I would definitely try giving him some marijuana, see if it would lighten his mood. I wouldn't destabilize him, though, by taking him off the ECT and the psychotropics to see if the marijuana would be sufficient, because it would just be too dangerous. But I really wish that if we could flash back to when Jonah was 6, that we could start with medical marijuana. I would absolutely recommend, I would, if it were me, I would try that first and see what kind of benefits I would get, because as I mentioned, it's just so easy. I mean, it's so, what I mean is it's so benign compared to these other treatments.
Yeah, I mentioned to you here at Autism Society San Francisco Bay Area about 2 weeks ago, we held a cannabis clutch. It's illegal, of course, medical cannabis is legal in California. So we held an event which sold out kind of quickly and had a huge waiting list. There was such tremendous interest in medical cannabis for treating anxiety, severe behaviors, sleep, and also seizures in a subset of the kids. And certainly there is a lot of anecdotal evidence of at least some efficacy. Again, not to treat the underlying autism, but to treat some of the more disabling symptoms. And yeah, it's a very, very hot topic. And surprising, Pennsylvania is still illegal out there.
Well, it's legal. It maybe just passed in the last year or so. Medical marijuana became legal, but I still don't even know how one would procure it, even if one had any of the conditions for which it's legal in this state. So it's still
Well,
very
come to
new.
my neighborhood where there's a dispensary on every corner.
Yeah.
Yeah, it's like they might as well just have walk-up windows now, or just like little carts for it, out here. It's yeah. Anyway, that's another subject for another webinar, I think. All right, this is a question that's you've already addressed most of it, but it's sort of packaged in one package. What options are there for ASD adults who have infrequent but high physical aggression toward others and are triggered by their own internal thoughts and wanting the world the way they want to work the way they want it to? Polypharmacy is not working and causing side effects, and nor is cognitive behavioral therapy.
Well, so it sounds like the individual that this person is referencing sounds pretty high functioning if they're talking about, that the person is, kind of his own thoughts are causing him to engage in this aggressive behavior, and cognitive behavior therapy has been tried, which you would only do with someone who, obviously could converse and engage in, this kind of a typical, therapeutic relationship. And I have to say, I don't know much about that population, the high-functioning end of the spectrum, and what drives rage in individuals such as the one described. So all of the families with whom I've connected and the kids I know who get ECT all have significant intellectual disability as well as autism, and their rages are not consciously driven. They don't have any control over them. So I don't know how much control the individual in the question, has over his behavior. It sounds like if it's triggered by his own thoughts, it may, but I'm sorry, I don't really have any insight as to options that would be beneficial for that individual, and I don't want to mislead anybody into thinking that I know anything about that end of the spectrum.
Let me ask kind of a follow-up question to that. One thing that definitely came up often in our cannabis clutch was this idea that Well, you know, compared to lots of other things in autism, at least the medical cannabis has few side effects.
Uh-huh.
In a way, maybe a parent in that situation, would you maybe say, well, ECT doesn't really have terrible side effects either. Maybe try it and see if it helps. And if it doesn't help, move on with your life and try something else. I mean, what do you think about
Absolutely.
that?
Yeah, the side effects are pretty mild, as I said. They're mostly headache and nausea, and maybe some short-term memory loss around the acute course. But what I will say is that you'll know pretty quickly. Unlike a lot of medications that might take, you know, weeks and weeks or even months to build up in the system, and then you're not really sure if you see a therapeutic effect or not because you have to get exactly the right dose. You should know within about 3 weeks if ECT is going to be helpful, and so then you can either keep going or discontinue it, and you'll know, you know, that you've tried it.
All right. Does Kennedy Krieger treat adults? Now, that's not where you're getting ECT now, right,
It's
Amy?
not. No, we
Yeah.
never got ECT at
You
Kennedy
never
Krieger.
got ECT at Kennedy Krieger, right?
And no,
So
it doesn't. Kennedy
I
Krieger
think
is
that,
for kids under 21. They sometimes, you know, will, in, you know, extreme circumstances, take somebody who's a little bit older, but they definitely have a focus on the pediatric population.
well, that's true with all autism, everything,
Yeah.
you know. Who has expertise in treating people with autism using ECT? I mean,
Well, if you look at the EASY Foundation, we do have a resource guide specifically on ECT practitioners, and everyone on that guide has treated kids with autism, has, you know, and is open to doing it. So if you happen to live by one of those providers, then that's who you should go to. If, I will say, you don't live near any of those providers, certainly shoot me an email if you want me to reach out to my network and see if I can find somebody who might be amenable, because I've done a lot of work with ECT organizations, and I have a lot of contacts who are in that world, and can certainly shoot an email to somebody and say, do you know someone in Nebraska or Ohio, you know, to who would provide ECT to an autistic teenager.
got it. Somebody is confused, writing in a question about is ECT not for somebody who is 26 years old? No, I think the implication here isn't that this is just for the pediatric population. This is
Right.
for, yeah. For
ECT has been used on I know an autistic child who started receiving ECT when he was 8, and of course ECT is typically used on geriatric patients. So across the lifespan, ECT is therapeutic.
Right. Okay, we are just about at our hour point, and is there anything else you want to add before we close? This was wonderfully informative, and I'm so glad we recorded it. And we will share, again, we will share the recording with everybody who registered for this, and we will post it on our website as well. And as I said, in the fall, we are planning to have an online symposium on severe behaviors, and for everybody who's on this call and listening, we'd love to have your feedback about ideas for speakers and ideas for topics, even ideas for format for this. It will be kind of a webinar-based presentation, but also we want to feature some online interactive sessions as well. So keep that in mind, and you can reach us at info@sfautismsociety.org. Okay? All right, Amy, thank you so much for sharing your incredible wisdom and experience with our audience. I really appreciate it.
Oh, thanks, Jill. Thanks for having me.
Okay, bye, everyone.
Bye.